Good morning, everybody. Thank you very much for coming here. I'm Dr. MD Mofijul, and today we will discuss one of the most important examinations in obstetric ultrasonography, the targeted imaging for fetal anomaly scan, commonly known as TIFFA scan. International Society of Ultrasound in Obstetrics and Gynecology developed standard guidelines of mid-trimester anomaly scan or TIFFA scan. These are globally accepted guidelines. This presentation is primarily based on the current ISUOG, that is ISUOG recommendations, together with practical experience accumulated during the routine fetal anomaly scanning. Most missed anomalies occur not because sonological knowledge lack, but because an anatomical structure was never examined. Therefore, throughout this lecture, we will repeatedly return to one concept: never scan randomly, always scan systematically. We shall begin with the ultrasound optimization, then ISUOG checklist, then standard image planes, image quality criteria, practical scanning tips, common mistakes, impression and disclaimers. Before looking at the fetus, we must optimize the ultrasound machine. Almost all structural abnormalities are first recognized on high quality grayscale images. Therefore, optimize the overall gain, adjust the depth appropriately, position the focal zone at the level of interest, and enlarge the region of interest so that the structure occupies most of the screen. Don't blame the machine before checking your settings. Sometimes a simple adjustment of gain, focal zone or probe angle dramatically improves image quality. Always remember that ultrasound is highly operator dependent. Now come to the ISUOG checklist. This is the ISUOG checklist. If you follow this checklist during every examination, the chances of missing a major anomaly decrease significantly. Never rely on memory. Instruct your assistant to tick on the planes of scanning when examined done satisfactorily. A checklist protects both the fetus and the sonologist. Let us briefly go through the checklist. Patient's particular LMP, EDD, POG, placenta, licar, chorionicity, etc. The next step is fetal biometry. Measure biparietal diameter, head circumference, abdominal circumference, femur length. Next comes cervical length assessment whenever clinically indicated, better by TVS. Before discussion of the actual scan plane, let's see the brain anatomy. Watch the first image of the lateral view of the brain. Look at the three lines: red lines, yellow lines and blue lines. The red one crossing the ventricular area, the yellow one is crossing thalamic area but not crossing the cerebellum. The yellow line and the red line both are not crossing the cerebellum. It means during BPD measurement you will not get cerebellum. If you get cerebellum, you are in the wrong plane. The blue line forming the transcerebellar plane, where you will get transcerebellar diameter, cisterna magna and nuchal fold thickness, etc. In between these two lines, that is in between the blue and yellow line or in between blue and red line, there is a variable angle of 30 to 45 degrees. So if you get cerebellum during BPD measurement, you are in a wrong plane. Now come to the anatomy of ventricular system of the brain. See the above blue curved part, which is the lateral ventricle. There are two lateral ventricles. The left one is first ventricle, right one is second ventricle. These two are draining into the third ventricle through foramen of Monro. Third ventricle is situated in between the two thalami. The third ventricle is so small that normally it is not visualized by normal ultrasonography. If the third ventricle is visualized, it is an abnormal finding. Though I have shown you here for discussion, the third ventricle is connected with the fourth ventricle through aqueduct of Sylvius. The fourth ventricle is connected or continued into the spinal cord. The subarachnoid space is connected with ventricular system through the foramen of Magendie, which is present in the median portion of the fourth ventricle, and two lateral foramina which are called foramina brusca. The cisterna magna is present posterior to the cerebellum, which is a part of subarachnoid space. Cisterna magna is a part of subarachnoid space. Now we begin the anatomical survey of the fetal brain. This is the transventricular plane of fetal brain showing the CSP, cavum septum pellucidum. Cavum septum pellucidum is a small rectangular or diamond shaped space between the two medial wall of the two lateral ventricles. CSP is not a part of ventricular system. CSP is not a part of ventricular system. It's a potential space between the two medial wall of the two lateral ventricles. Here see full screen view, magnification of the cranium, more than 75% of the screen, falx present, ventricles, lateral ventricles. Lateral ventricles should be measured in the paraesophageal fissure level. CSP, cerebellum should not be seen. BPD from out to out. BPD measurement from out to out, not out to in, out to out. Our caliper placement should be perpendicular. Ventricles measurement should be in to in. These are the more images of ventricular planes. This is transcerebellar plane. From transventricular plane till the probe 30 degree down, then you will get transventricular plane. It should show falx, CSP, CM, NF, dumbbell shaped cerebellum out to out, cisterna magna, nuchal fold thickness in full screen view with magnification of the cranium more than 75% of the screen. More than 75% of the screen. More images of transcerebellar plane. Here you can see that in the left sided image you are getting the thalamus, but in the right sided image you are not getting the thalamus clearly. This is for the tilting of your probe, but both are in transcerebellar plane. Complete agenesis is better than partial agenesis of corpus callosum. Here the curved corpus callosum is shown above the lateral ventricle, the sagittal section of the brain. See, above the lateral ventricle you are getting the curved shaped corpus callosum, and below the lateral ventricles you are getting thalamus and third ventricles. The third ventricles is not visualized because if You can see third ventricle. This is abnormal finding. Normally, the third ventricles are not seen or not visualized. Now come to the upper lips and nose. Full screen view, magnification more than 75% of the structures, coronal views with appropriate gain, nasal tips and two nostrils should be seen, chin rounded or triangular. More images of upper lips, see the nostrils, tip of the nose, lips, etc. Come to the mid sagittal profile view. Here the head and upper thorax should be in more than 75% magnification with full screen view, and no zygoma should be seen with appropriate gain. Profile angle around 45 degrees in neutral position. No eye socket should be seen. Nasal bone ends well visualized. Measure the NB or nasal bones from end to end. More images of profile view. Come to the orbit and bulbs view. Full screen view and more than 75% magnification, axial section with appropriate gain. Two eye socket looking up within 20 degrees. Lenses should be visualized in both sockets. Measurement of iodine BOD is not mandatory as per ISUOG guidelines. Measuring iodine BOD are not mandatory as per ISUOG guidelines, but if you measure, you will get confirmed information about the correctness of the distance between the two orbits. So you can measure the iodine BOD. More images of orbits and bulbs. Now come to the hard palate view. Just tilting your probe slightly downwards from the orbital view, you will get hard palate. In axial section, appropriate gain, bone appears bright, and beaded appearance of palate on both sides should be visualized. More images of hard palate. See the beaded appearance of the hard palates. After brain, the most important structure of CNS is spinal cord. In the sagittal or parasagittal plane, you must show the whole spinal curvature with sacral curve, CVJ, with trunk track appearance, skin covering spine and entirely, and sacral curvature should be seen. Again, see, the skin should be seen in full screen view and magnification more than 75% of the structures. More images of spine, sagittal or parasagittal. See the CVJ, spine, sacrum. Now come to the coronal views of spine. Here you see with appropriate gain both iliac bones visible. See both iliac bones. and baby corn appearance of 7 to 8 vertebrae. Kidneys should not be visible. These are more images of coronal views of spine. Now come to the cardiac screening. Heart. This is 4-chamber heart. Always the images should be in full screen and magnification should be more than 75% of the structure or more than 75% of the heart. Magnification should be more than 75% of the screen. Aorta posterior single rib, both sides with apical view. Cracks should be visible, clear. Intraventricular septum should be visible clearly. Atria and ventricles with maintaining the offset, the right sided moderator band, and minimum 2 pulmonary veins should be seen draining into the left atrium. Situs should be always determined. See, left sided fourth chamber view and right sided image showing the stomach. Both structures are to the left side, that is stomach is to the left side and the apex is also to the left side, so this is situs solitus. Situs always should be determined. Rate, rhythm and axis all should be determined clearly. And see, the M-mode cursor is passing through the ventricle and atrium, and ventricular rate and atrial rate both should be synchronizing in normal heart rate or normal heart rhythm, and axis should be within 45 plus minus 20 degrees. If there is left ventricular or left axial deviation, there should be some outflow tract abnormality, and in case of right axis deviation, there will be some structural abnormality of the heart. More images of apical and transverse views of fourth chamber view. Come to the LVOT view. After obtaining a satisfactory fourth chamber view, sweep cephala to visualize the left ventricular outflow tract. The aorta should arise smoothly from the left ventricle with uninterrupted septo-aortic continuity. The vessel should appear as a single vessel without branching. The view confirms the normal connection between the left ventricle and the aorta. When the aortic root becomes visible arising from the left ventricle, the image is termed the 5-chamber view. When the aortic root becomes visible arising from the left ventricle, the image is termed as 5-chamber view. Although the aortic root is not a true cardiac chamber, its visualization is crucial for confirming normal outflow anatomy. More images of LVOT. Now come to RVOT. Further cranial angulation demonstrates the right ventricular outflow tract. Here, the pulmonary artery should arise from the right ventricle and curve gracefully behind the ascending aorta. See, the branching of the pulmonary artery. Branching artery confirms that this is actually right ventricular outflow tract. left ventricular outflow not branches, but right ventricular outflow always branches. More images of RVOT. See the branching right ventricular outflow tract. Now 3VT views. The 3 vessel and tracheal view, commonly known as 3VT view, is among the most powerful screening planes. 3 vessels should be identified in sequence: the pulmonary artery, the aorta, and the superior vena cava. Their relative sizes should follow the pattern: pulmonary artery greater than or equal to aorta, which is greater than superior vena cava. The relationship with the trachea must also be assessed carefully. More images of 3VT view. Now come to extended cardiac screening. Once the basic screening examination is complete, more advanced cardiac evaluation can be performed. This includes the aortic arch, ductal arch, bicaval view, the right subclavian artery assessment. These additional views significantly increase the detection rate of complex congenital heart disease. And this is the NRSA, or normal subclavian artery views. In full screen or proper magnification, color flow Doppler shows the right subclavian artery curving in front of the trachea, extending to the right arm. If the right subclavian artery curving from the back of the trachea, then it will be ARSA. Here in normal subclavian artery, it curves in front of the trachea. If it curves from the back of the aorta, back of the trachea, it will be ARSA, that is aberrant right subclavian artery. ARSA is a soft marker of Down syndrome. For more descriptive learning about fetal cardiac screening, watch my YouTube video. This is the YouTube video link. Continue with abdominal assessment. Confirm the stomach, J-shaped stomach. Evaluate the bowel appearance. Is there any echogenicity? If echogenicity is equal to the bones, this will be called as echogenic bowel. And see the umbilical vein, single ray both sides, 3 spinal processes, aorta posteriorly, measure out to out. This will be abdominal circumference. Abdominal circumference or AC. Come to the abdominal kidneys. Abdominal views or kidney views. Assess both kidneys with proper magnifications. Axial anterior-posterior view with appropriate gain. Abdominal skin should be seen with 3 spinal process. No stomach should be visualized. Hypoechoic renal pelvis. A caliper should be on to on. See the both-sided renal pelvis. Urinary bladder and 2 umbilical arteries. Coronal section showing stomach bubble, showing umbilical urinary bladder. showing urinary bladder and two umbilical artery are visualized both side of the urinary bladder. Now cord insert view. With the appropriate gain, no stomach bubble should be seen. Single rib, both sides, 3 spinal processes. Intra and extra abdominal cord should be visualized. Intra and extra abdominal cord. Now come to upper extremities. Confirm the presence of both arms and both legs, and confirm the presence of 2 upper extremities, and see here the upper extremities with the appropriate gain. 4 to 5 fingers should be seen and little finger should be visible. Hands should be open. More images of upper extremities. See, both bones of forearm should be visualized. See the ankle view, and confirmations of both lower legs should be confirmed. With appropriate gain, skin line seen, leg and foot should be visualized. No extra toes should be visualized. This is ankle view. More images of ankle views. Lower extremities are footprint view. In footprint view, if you see leg bone, there must be club foot. Here you can see 5 toes, no limb bones in appropriate gain. No limb bones should be seen. If you can see limb bones with footprint view, there will be obviously club foot. Normally footprint and limb bones should not be seen in same plane. More images of footprint views. Now cervical length measurement. TIFFA is the gold standard to measure cervical length. In this view, bladder should be evacuated properly. Bladder should be empty. In TIFFA scan, the sagittal view of the cervix, measurement should be from internal os to external os in straight line, single line. No compression to the cervix should be done. The essential biometric measurements, BPD, SC, AC and FL. The first 3 are already discussed. Now we shall discuss the remaining parts. Again come to the abdominal circumference view, because to evaluate the estimated fetal weight, abdominal circumference is the most crucial, most important. Again see, single rib on each side, stomach bubble and umbilical vein should be visualized in the plane. 3 spinal processes, aorta posteriorly, measurement out to out. A long bone or female length measurement. full screen view. Structures occupying more than 75% of the screen. Single skill line should be seen. 45 to 60 degree angulation. Our caliper should be end to end. Now at last come to the final point, that is impression. The presentation provides several examples of acceptable impressions for a normal anomaly scan. Examples include: no definite measure fetal structural abnormality is defined in the visualized fetal anomaly, or screening for targeted fetal anomaly scan is within normal limits, or no major fetal anomaly is detected as far as visualized. Notice the careful wording. Each statement acknowledges that the findings are limited to the structures that could be visualized. This wording is important because prenatal ultrasound has no limitations. Avoid using absolute statements such as normal baby or no anomaly present. Such statements are scientifically incorrect and may create unnecessary medical risk. Every TIFFA report should include an appropriate disclaimer. The presentation emphasizes that the examination presents assessment of fetal anatomy at the time of scanning according to accepted obstetrics ultrasound practice and current ISUOG recommendations where applicable. Patients should therefore understand that a normal anomaly scan significantly reduces but doesn't eliminate the possibility of congenital abnormalities. Clinical management should always be based on the complete clinical picture, including laboratory investigations, genetic testing, follow-up imaging, and specialist consultations where indicated. The presentation also reminds us that fetal sex has neither detected nor disclosed. This is an important legal requirement in India and reflects compliance with the PCPNDT Acts. Before concluding, let us summarize the most important learning points. First, always perform the TIFFA scan systematically using standard image criteria. Second, always use a checklist. Third, never hurry. Remember that a few extra minutes spent during scanning may prevent a lifetime of regret from a missed anomaly. Fourth, preserve adequate documentation of every mandatory image plane. Fifth, if visualization is suboptimal, do not hesitate to rescan after maternal movement, fetal movement, bladder emptying, or even on another occasion. Sixth, whenever you encounter a doubtful finding, reassess it in multiple planes and in different fetal positions before reaching a conclusion. Seventh, and perhaps the most important practice message, never issue a TIFFA report without optimum cardiac visualization or optimum cardiac evaluation. Finally, always think about the medical aspect before writing your impression and always include an appropriate disclaimer. With that, we come to the end of today's lecture. I sincerely hope this session has helped you understand not only what should be examined during a TIFFA scan, but also how to examine it systematically and why every image matters. Remember, fetal anomaly scanning is not merely a technical procedure, it is a responsibility. Every scan has the potential to change the course of a pregnancy and profoundly influence parental counseling and clinical management. Therefore, always strive for three principles: be systemic, be patient, be humble. Thank you very much for your attention. I wish you all the very best in your practice and your journey toward excellence in fetal medicine.